Good afternoon and welcome to today's press conference. Bienvenue à cette conférence de presse. Today we have with us Health Minister Jean-Yves Dr. Mona Nemer, the Chief Science Advisor, Dr. Michael Strong, the President of the Canadian Institutes of Health Research, and Dr. Theresa Tam, Chief Public Health Officer for the Public Health Agency of Canada. My name is Mia Rabson and I will be moderating the press conference today. If you are online and have a question, please use the raise hand function. We will be taking questions in the room first, and I'm told we'll have about 30 minutes for questions after the statements are made, and we will start, I believe, with Minister Duclos.
Good afternoon, bonjour à tous et à toutes. Merci de me donner la chance de vous parler aujourd'hui en compagnie de mes collègues, les docteurs Tam, Nemer et Strong. Hospitals across the country are facing major challenges and emergency rooms are overwhelmed. Health workers are experiencing significant strain and are running out of steam. Canadians are extremely concerned, and so am I. Canadians, patients, caregivers, and health workers all want results, and we remain committed to working collaboratively with all our partners to do things differently. We will do so by focusing on the ends rather than the means, because as we can see now, the old way of doing things does not work. I remain committed to working with my provincial and territorial counterparts to improve health services for everyone. And that is why at last month's Health Ministers meeting, I confirmed that we are ready to further increase healthcare investments through the Canada Health Transfer. In addition, we are ready to invest more in funding through tailor-made agreements with provinces and territories that will allow us to provide better care to Canadians. We owe it to Canadians to come together and find immediate and longer-term solutions to address those challenges. This brings me to my first update. Parents and caregivers have been particularly concerned about their difficulty to find children's analgesics. As of today, over 2 million additional bottles of these medicines have been made available to parents and caregivers through increased domestic supply and foreign importation. I can also confirm that the drug company Alon estimates that an additional 800,000 bottles for this month will be available at pharmacies and retailers across Canada. The influx of new products should help parents manage their kids' symptoms at home as we continue to experience a surge of respiratory illnesses across the country. With cold and flu season off to an earlier start than anticipated, we need to protect the overburdened health workers by doing everything we can to stay healthy, especially as we enter the holiday season. That includes staying up to date on our vaccinations. There are safe and effective vaccines available for both the flu and COVID-19, and these are available to everyone in Canada over the age of 6 months. And today is a great anniversary in that regard. 2 years ago, on that exact date, the largest vaccination campaign in the history of Canada was launched. 95 million doses of vaccines against COVID-19 have been administered since then. The National Advisory Committee on Immunization has also recently recommended that children 6 months of age and older can safely receive a COVID-19 vaccine at the same time as other recommended childhood vaccines, including the flu shot. This being said, we're still learning about COVID-19, and there remains much to learn about how it affects human health over the long term. What we do know is that even a mild COVID-19 infection or reinfection can cause real long-term consequences for individuals, communities, and our healthcare system. Evidence shows that almost 15% of adults who were infected with COVID-19 experience longer-term COVID-19 symptoms. The nature and severity of these long-term effects can vary from person to person, and these effects are collectively known as post-COVID-19 condition, also referred to as long COVID. To support Canadians who are living with the longer-term effects of that virus, The Government of Canada is working with all experts to better understand this condition. In July 2022, Dr. Nemer, Canada's Chief Science Advisor, established the Task Force on Post-COVID-19 Condition to develop a scientific framework for managing long COVID. Pour soutenir les Canadiens et les Canadiennes qui vivent avec les effets à long terme parfois sévères de la COVID-19, le gouvernement du Canada travaille avec les experts pour mieux comprendre le syndrome post-COVID, aussi connu comme la COVID longue. En juillet 2022, la Dr. Nemer a créé un groupe de travail sur la COVID longue. Les recommandations du rapport publié aujourd'hui identifient les mesures à prendre pour faire face aux répercussions sanitaires et socio-économiques de la COVID longue. Le rapport complet devrait être publié à la fin janvier. Je tiens à remercier la Dr. Nemer et les membres de son groupe de travail pour tous leurs efforts. Les recommandations du groupe de travail guideront un plan d'action conjoint pour tous les partenaires et gouvernements afin de soutenir les Canadiens vivant avec le syndrome post-COVID. Depuis, puisque la science doit continuer d'être au cœur de nos prises de décision, nous investissons dans de nouvelles recherches sur la COVID longue. Grâce aux 20 millions de dollars octroyés aux instituts de recherche en santé du Canada dans le budget 2022, les IRSC ont lancé le 11 octobre dernier un appel à mettre sur pied le réseau canadien de recherche sur le syndrome post-COVID. Ce réseau interdisciplinaire ciblera la recherche relative aux effets à long terme de la COVID-19 sur la santé des gens et des systèmes de santé au pays et nous aidera à améliorer notre compréhension des conséquences sur la santé mentale et physique des gens qui en sont malheureusement atteints. En outre, l'Agence de la santé publique du Canada a reçu 9 millions de dollars pour soutenir l'élaboration et la diffusion de lignes directrices fondées sur des données probantes et d'outils d'application des connaissances liées à la COVID de longue durée. Ces outils reflèteront les impacts sur les diverses populations du pays et seront importants tant pour les cliniciens que pour les patients. Les effets du syndrome post-COVID sont troublants, surtout pour ceux et celles qui vivent avec la condition et dont la santé et le bien-être sont durement affectés. Et une chose est certaine, la meilleure prévention est de prendre des mesures pour éviter d'être infecté. Cela inclut la vaccination, y compris les doses de rappel, et la mise en pratique de mesures individuelles de santé publique, comme le port d'un masque bien ajusté et la prudence dans les endroits publics. Et cela m'amène au dernier sujet nécessitant une mise à jour. Le 1er décembre, nous avons ouvert le processus de demande de la nouvelle prestation dentaire canadienne provisoire pour fournir aux familles admissibles des paiements directs et non imposables. Les parents peuvent demander la prestation en ligne par l'intermédiaire de Mon dossier de l'Agence du revenu du Canada ou par l'intermédiaire du centre de contact avec la clientèle de la même agence ou simplement en cliquant sur canada.ca/dentaire. Jusqu'à présent, plus de 57 000 demandes ont été reçues pour un total d'environ 91 000 enfants, aidant ainsi beaucoup d'enfants à garder leur plus beau sourire. Ayant fourni des mises à jour sur plusieurs dossiers, je passe maintenant la parole à la Dr. Nemer qui va prendre quelques minutes pour vous présenter les points saillants des travaux effectués par le groupe de travail sur le syndrome post-COVID et les recommandations qui en découlent. Merci.
Thank you. Merci, Monsieur le Ministre. Bonjour tout le monde.
Hello, everyone.
Over the course of the pandemic, evidence has emerged that some individuals who have been infected with the SARS-CoV-2 virus may develop long-term symptoms, suggesting that COVID-19 can develop into a chronic illness. These symptoms range from muscle pain, shortness of breath, and extreme fatigue to what's called brain fog, gastrointestinal issues, and even heart palpitations. Collectively, they've come to be known as post-COVID-19 condition, or PCC, also known as long COVID. We don't fully understand what causes certain individuals to develop PCC or what leads to the different disease manifestations. We don't know why women are twice as likely as men to contract it. We don't know why it can accelerate the onset of other chronic conditions like diabetes and heart disease. But it is evident that PCC is a serious condition that can have, at times, irreversible health consequences. In light of all this, as the Minister said, I brought together experts and practitioners from across the country to provide the government with advice on ways to address PCC in Canada. In developing the recommendations, which we are releasing today, we looked at existing scientific evidence and heard from healthcare providers and people with lived experience. We spoke with many people who are suffering life-altering physical impairments. Their stories were heartbreaking. One individual reported feeling trapped in their own body. Another said they were treated with disbelief in the workplace. Still others recalled feeling abandoned by their community. And several reported difficulty accessing healthcare and social support. Most had lost their job. And this is my other point. Beyond the health problems, PCC also affects the daily lives of people, from their ability to work, to caring for their families, to interacting with their communities. And this can have significant societal impacts. For example, estimates from the US suggest that 10 million people with long COVID could carry an economic cost of $3.7 trillion a year when you take into account lost quality of life, lost earnings, and higher spending on medical care. With 1.4 million people in Canada already reporting symptoms, it's not difficult to imagine the serious ramifications for our own economy. Clearly, the risk of the disease is not evenly distributed, yet its impacts will be universally felt. So what do we do? To start, we need to acknowledge that PCC is real, that COVID-19 manifests itself as an acute, but also as a chronic illness. À l'heure où plusieurs personnes ne veulent plus entendre parler de la COVID, we're all suffering to a certain extent from COVID fatigue, nous devons faire preuve de vigilance. Le risque d'infection et de réinfection par la COVID est toujours présent. Cela signifie qu'il existe un risque continu de développer le syndrome post-COVID. PCC. Les vaccins contre la COVID-19 réduisent considérablement le risque de développer des complications à long terme et contribuent donc à réduire la menace pour les personnes et la société. In addition to their well-known protective effects against severe COVID-19, it is now clear that vaccines also contribute to reducing the risk of PCC. Nous devons également mettre en place de meilleurs réseaux qui relient les chercheurs aux prestataires de soins de santé et aux patients. Cela permettra de développer des méthodes de collecte et de partage rapides et efficaces des données et des informations afin d'améliorer les soins aux patients. What we learn from addressing PCC will likely benefit a broad range of Canadians, including those suffering from other infection-associated chronic conditions, such as Lyme disease, a condition that may become more common due to climate change. With the SARS-CoV-2 virus still spreading and the healthcare system already overburdened, it is vital that we act now to care for affected individuals and protect many more from serious post-infectious complications. Thank you, and now I'll pass it on to Dr. Strong.
I'm pleased to be participating in today's event alongside Minister Duclos, Dr. Tam, and Dr. Nemer. At the Canadian Institutes of Health Research, we've been heavily engaged in Canada's research response to COVID-19. We work closely with the Public Health Agency of Canada and our federal partners to identify research gaps and priorities. From the start of the pandemic, the government recognized the important role of research in mounting a response to this. That's why CIHR received significant dedicated funding for COVID-19 research beginning in 2020. We have used this funding to rapidly mobilize Canada's research community to generate evidence needed to understand the virus and to make decisions on how to best protect Canadians. As the pandemic evolved over time, so too has our research response. The first projects funded in the spring of 2020 focused on containment measures such as vaccines, diagnostics, and therapeutics. I think I might mention at this point, Canada was one of the very first countries in the world to mount a unified research program after that. We led in many areas. Later research has focused on the broader impact of COVID-19 on the health of all Canadians, particularly vulnerable groups such as children and seniors, and the impact of caring for COVID patients on our hospitals. To keep pace with the emergence of new variants such as Omicron, we funded the Coronavirus Variants Rapid Response Network, also known as COVARNet, in March of 2021. This network is composed of researchers from across the country who have produced vital information on the different virus variants to help guide our public health response and to prepare for future pandemics. As the Minister and Dr. Nemer have noted, post-COVID-19 condition is a serious issue affecting many Canadians. This is a new condition for which we are still defining its clinical features and determining how best to treat it and support the recovery of patients. It is critical that we focus our efforts on understanding this potentially devastating disease. As part of our ongoing research response, we have already funded some research on PCC, or post-COVID-19, that will contribute to this understanding of the condition. For example, we are funding the Canadian COVID-19 Prospective Cohort Study, or CANCOV for short. This study involves more than 2,000 patients in Canada's 4 hardest-hit provinces: Quebec, Ontario, Alberta, and British Columbia. The study will help us to better understand both short and long-term outcomes in patients and their caregivers. Today, Minister Duclos has announced an important new step in the evolution of our COVID-19 response. This is the creation of a new national network focused on post-COVID condition, as clearly alluded to by Dr. Nemer and her task force as being a need. This network will be supported with $20 million in new funding provided to CIHR in last year's budget. We designed the network to ensure alignment with the goals and actions outlined for research in Dr. Nemer's task force report. And as such, the objectives to the network are very focused. It will, first and foremost, provide a platform to strengthen Canada's capacity for research on post-COVID-19 condition. It will enable comprehensive and timely understanding of the biological, clinical, mental health, health systems, and population health impacts of post-COVID-19 condition. It will engage relevant stakeholders at the local, national, and international level to support coordination of research activities. And lastly, it will swiftly mobilize research evidence to support an equitable response to the post-COVID-19 condition. As CIHR, we launched a competitive process to create the network in October. This process was led by the Centre for Research on Pandemic Preparedness and Health Emergencies, an initiative of the government which is housed at CIHR. The research centre was set up to continue to address COVID-19 and to help us ensure timely research and highly trained experts are in place for future emergencies. We will be ready to announce the recipients of the funding of this network early in the new year. The work of this network will make a major contribution to achieving the vision of the task force report in supporting Canadians affected by post-COVID-19 condition and reducing its impact. Merci, and thank you very much.
Thank you very much. Bonjour à toutes et à tous. Nationally, SARS-CoV-2, influenza, respiratory syncytial virus, or RSV, and other respiratory viruses continue to cause significant levels of infection in our population. Very young and elderly people, as well as those with pre-existing medical conditions, continue to be at the highest risk of serious illness. While increases in respiratory virus-related illnesses are expected at this time of the year, co-circulation of these viruses is causing significant strain on our healthcare system. Partout au Canada, le SARS-CoV-2, la grippe, le virus respiratoire syncytial, ou VRS, et d'autres virus respiratoires demeurent la cause d'importants niveaux d'infection au sein de notre population. Les patients très jeunes, les aînés ainsi que les personnes souffrant d'une affection persistante sont toujours les plus susceptibles d'être gravement malades.
to be at highest risk for
Même
serious
si pendant cette
illnesses.
période de l'année, une augmentation des
While
maladies
increases
liées à un
in
virus
respiratory
respiratoire est
virus-related
attendue,
illnesses are
la
expected
circulation
at this time of
simultanée
year,
de ce virus
the
met à rude
co-circulation of these
épreuve nos
viruses
systèmes de
is
santé,
causing
soins de santé.
significant strain on our healthcare
Surveillance
systems.
indicators, including clinical and wastewater testing, show that SARS-CoV-2 is still circulating across the country. And while we are past the peak of the last COVID-19 resurgence, it is too soon to let our guard down. In Canada, variations in population level of immunity and current global trends suggest that an uptick in COVID-19 could occur in the new year. In recent weeks, genetic sequencing data on SARS-CoV-2 viruses show continuing increase in immune-evasive variants, notably BQ1 and BQ1.1, while the previously dominant BA5 lineage variants are declining. With the increased prominence of these variants in Canada, at a minimum, we could see a slower decline and a higher plateau in the number of infections, as well as hospital admissions in Canada, as this respiratory virus season plays out. In terms of the other respiratory viruses circulating, RSV activity has leveled off nationally, and infections are declining in some jurisdictions. This means activity levels are now within the expected range for this time of year. In contrast, influenza is continuing to trend well above expected levels for this time of the year, but this varies across the regions. Most worrisome is the increase in influenza-related hospitalizations. The IMPACT network, which provides data on pediatric hospitalizations due to influenza, has noticed sharp increases in multiple sites across the country. These data also suggest a shift to a higher proportion of hospitalized cases occurring in the 10 to 16-year age group compared to seasons prior to the pandemic. However, the highest cumulative hospitalization rates for influenza continue to be among children under 5 years of age. Currently, the weekly number of pediatric hospitalizations being reported is above levels typically seen at the peak of the influenza season. Tragically, due to this high number of pediatric cases, we're also seeing higher than usual number of ICU admissions and deaths due to influenza in children. Le plus préoccupant est toutefois l'augmentation des hospitalisations liées à la grippe. Le réseau IMPACT, qui fournit des données sur les hospitalisations d'enfants en raison de la grippe, a relevé des augmentations marquées dans diverses régions du pays. Ces données suggèrent également un changement vers une proportion plus élevée de cas hospitalisés chez les 10 à 16 ans, comparativement aux saisons précédentes de la pandémie. Toutefois, le taux d'hospitalisation cumulatif le plus élevé pour la grippe continue d'être élevé chez les enfants de moins de 5 ans. À l'heure actuelle, le nombre hebdomadaire d'hospitalisation d'enfants déclarés est supérieur au niveau habituellement observé ou plus fort de la saison de la grippe. Malheureusement, en raison de ce nombre élevé de cas chez les enfants, nous observons également un nombre plus élevé que d'habitude d'admissions aux soins intensifs et de décès en raison de la grippe chez les enfants. To date, laboratory data indicate that this year's influenza vaccine is a good match to circulating strains and therefore is likely to help protect against serious influenza disease. Influenza vaccine takes about 2 weeks to provide optimal protection. So as we rapidly approach the holidays, now is the time to get vaccinated if you have not already done so. Flu shots are available across Canada and can be given to adults, teenagers, and children as young as 6 months of age. The flu shot can also be given at the same time as the COVID-19 vaccines. There are now more options for COVID-19 booster doses for children 5 to 11 years of age, and the recent approval of a bivalent vaccine for this age group. If it has been 6 months or more since your last COVID-19 vaccine dose or COVID-19 infection, getting vaccinated now will boost your level of protection going into the holiday season. Staying up to date with the recommended vaccines provides an important foundation of protection. The results of the first population-based survey of adults across Canada, conducted between April and August of this year, show that close to 15% of those with a confirmed or suspected COVID-19 infection experience longer-term symptoms or post-COVID condition, with almost half of these individuals experiencing symptoms for a year or longer. While ongoing studies are needed, there is emerging evidence that the risk of developing post-COVID-19 condition is reduced if you have received 2 or more doses of COVID-19 vaccine prior to infection. As we move indoors and gather to celebrate the holiday season, I encourage you to build on the foundation that vaccines provide by taking additional personal protective measures. Together, these measures can provide very good protection against COVID-19 as well as other respiratory infections. When planning a holiday gathering, consider the potential impact of respiratory illnesses on your health and social plans, the health status and risk factors of the people you're gathering with, and the places you'll be gathering in. Properly wearing a well-fitted, well-constructed face mask in indoor public spaces or crowded settings, and taking steps to take the best ventilation possible are layers of protection that can reduce everyone's risk. Lorsque vous prévoyez un rassemblement pour le temps de fête, pensez
When
à
planning a holiday gathering,
possible de maladies
consider
respiratoires
the
sur
potential
votre santé
impact
et
of
vos
respiratory
plans sociaux.
illnesses on your health
À
and social
l'état de
plans,
santé et aux facteurs de risque
the
des
health
personnes
status
avec
and
qui
risk
vous serez en
factors
contact
of people you're
et
gathering
au
with,
lieu dans lequel vous vous
and the
réunirez.
places you'll be gathering
Le
in.
port un masque bien ajusté et bien
Properly
construit
wearing
dans les
a
endroits
well-fitted
publics
and
intérieurs ou
well-constructed
bondés,
face mask
la prise de
in
mesures
indoor
pour
public
assurer la
spaces or
meilleure
crowded
ventilation
settings,
possible
and taking steps to
constituent
get the best
d'autres mesures
ventilation
de
possible
protection
are
qui
layers
peuvent
of protection
atténuer le
that
risque
can
d'infection pour
reduce
tous.
everyone's risk.
Our healthcare system continues to be challenged by the additional burden of all respiratory viruses this time of year. The impact, particularly on children's hospitals, has already been overwhelming in many parts of the country. This holiday season, let's do the best we can to make our wishes for health and happiness come true by taking actions to protect ourselves and others from respiratory viruses. Happy holidays, joyeuses fêtes. Thank you, merci, miigwech.
Thank you. We'll start with questions in the room with 1 question and 1 follow. And our first question will go to Laura Osman from the Canadian Press.
Hey there. My first question is for the minister. I wanted to jump off of what you were saying about the government's willingness to increase the Canada Health Transfer, and if I'm hearing you correctly, also explore more tailored bilateral agreements with the provinces. I spoke to Adrian Dix last night, who said that he's still not clear exactly what the government is looking for in order to get those negotiations moving forward. So I'm hoping that you can kind of pull the curtain back a little bit, explain to us exactly how these negotiations work and what conditions you've put to the province and kind of a timeline for getting those talks moving.
Thank you, and I will gladly do so, taking the curtains back, as you say. And that brings me back to the last year, during which we had 12 meetings at the health minister's level, obviously many more meetings between officials and many others. And during those 12 meetings, with the leadership of Minister Dix in particular, and the leadership of other provincial health ministers, we made very serious and good progress on 2 big pieces. The first one was how to support healthcare workers, to retain them better, to recruit them, to recognize their credentials, to train them, and then on data. And because data saves lives, how we can have in Canada a modern health data system that provides data to healthcare providers, to nurses, doctors, specialist physicians, pharmacists, so that the data on people's health are available when these people end up in an emergency department, or they visit their physician, or they go to visit a pharmacist. So how do we make sure that that data supports their health and the work of workers? we were going to the Vancouver conference with great hopes that not only would we finally agree on all of that great work that Minister Dix and others had done, but also we would share that work publicly. Unfortunately, just a few days earlier, my health ministers received an order by their premiers not to speak about those results publicly. And that's an unfortunate thing, because before we come to the means that we need to achieve some ends, we need to agree on the ends and to speak publicly about them and the results that come from investing in workers and supporting patients. So where we are now is we're continuing our conversation. I've met all my health ministers. I've been speaking to them almost weekly in various ways, and we know we'll get to an agreement on outcomes at some point. But we need more work, and we need premiers to let us do that work.
Based on my conversation with Minister Dix, he was under the impression that he doesn't know what the federal government wants. And they might be willing to give it if they knew what the federal government was looking for. Is the ball in their court to come to you, or is it up to you to tell them exactly what criteria you're looking for?
The ball is in the Premier's court. At the health minister's level, we all agree. We've got a great relationship. We agree on the diagnostic. We agree on the problems and the solutions to those problems. We were in total agreement in Vancouver in private. The problem is that the premiers don't want us to speak about those outcomes and those results. They want to maintain a futile fight on dollars. And that's a futile fight because they ask for 35%. If you do the calculations correctly, we're already at 35%. If you do what premiers ask us to do, if you add the whole package, the cash transfers and the transfers that come with the tax points, we are at 35, roughly speaking. We were a bit above 35 during COVID-19, which we're roughly at 35 now, and we've been at 35% for the last 50 years almost. Now, in addition to CHT, the tax points, as we all know, we have been investing and we keep investing in the fight against COVID-19, $72 billion in total, plus all of the additional transfers for home care, mental health care, and long-term care, not even mentioning the $2 billion additional that we sent a few weeks ago to reduce backlogs in surgeries and diagnostics. So on the dollars, it's not a useful fight. If we were to only focus on 35%, we wouldn't do anything more. But the Prime Minister did commit that we would be investing even more in terms of resources. But we need to agree publicly and to speak publicly on the results based on the hard work that Minister Dix and many others did in the last year.
Next question by Valerie Bain from Radio-Canada.
Alors, plus tôt aujourd'hui, le
Earlier
chef du Bloc
today,
québécois
the leader of the
a
Bloc
accusé le
Québécois
Parti libéral de
accused the
prendre
Liberal
les patients,
Party
les Canadiens en
of
otage
taking patients hostage
par rapport au transfert en santé,
with regards
étant
to
donné
the
que les
healthcare
discussions achètent
transfers,
et qu'on n'a toujours pas d'entente,
given that there is still no
que
agreement.
si les provinces
The
qui ont des besoins
discussions
et
are
que vous avez
stalled,
les
that
ressources et que vous
provinces
ne les
have
donnez pas,
needs,
qu'est-ce que vous
you have
répondez à ça?
resources and you're not
Je réponds que si
unblocking
on
them.
parle des ressources
My
financières,
answer is that
le
if we're
gouvernement
talking about
canadien en
financial
fait déjà
resources, the
beaucoup,
Canadian government
et
is
beaucoup
already
plus
doing
que
a
ce
lot,
que d'ailleurs les
and
provinces
even
demandent.
much more than
Le
what the provinces are
35%
asking
dont
for.
les premiers
The
ministres parlent, on est
35%
déjà
that
là
the
à
premiers are
35%.
talking about, we're
Quand on fait
already
les calculs
there.
correctement,
If
on
you
a-
do the
quand on fait
calculations
la somme des
correctly,
transferts
if you do the
en
sum of
espèces, qui
transfers,
passe par le
of
transfert
cash
canadien en
transfers,
santé,
there's a
et les
Canada
transferts
Healthcare
par le
transfer
biais
and
des points
transfers
d'impôt, on est à
through
35%. On
the
était un peu plus
tax
haut que
points. We're
35%
a
durant
little
la
bit over
COVID-19, on est présentement à 35%.
35%.
Si on ajoute à ça le
If we
72
add to
milliards
that
de
the
dollars
72
qui continue d'aider les provinces et les
billion
territoires
dollars
à
that
lutter contre la
continues to help
COVID-19,
provinces
les
and territories fight
investissements
against
bilatéraux
COVID-19,
en santé mentale, en
bilateral
soins de longue
agreements,
durée, en soins à
investments
domicile, si on
in
ajoute
home
le 2
care,
milliards
long-term
de
care,
dollars qui
and
est en
mental
train
health,
d'arriver
if you
dans les
add
provinces et territoires pour
the
réduire les
72
retards
billion
en
that will be
chirurgie, en
asked to
diagnostic,
try to
on voit
reduce
là que les dollars, il y
the
en a
surgery
beaucoup,
backlog,
et beaucoup
there
plus
are
que
huge
ce
sums of
que
money
ce
and
gouvernement
much more
canadien envoie généralement aux
than what
provinces et aux
the
territoires.
federal
Sans parler du
government
fait que
generally
dans
sends to the
quelques
provinces
semaines,
and
en mars,
territories
le
in
transfert
March.
canadien en santé va augmenter d'un autre
The
10%.
Canada Health Transfer will
Donc,
go up another
c'est pas la
10%.
bonne discussion
So
à
this is
avoir. La
not
bonne
the
discussion à
correct
avoir, c'est quels
discussion
sont
to
les
be
résultats que
having.
l'on veut
The right
atteindre
discussion
ensemble.
is what
Et
are
la
the
bonne
results
nouvelle,
that
c'est
we
que
want
tous
to
les
reach
ministres de la
together.
Santé,
The good news is that all
incluant
the
moi-même,
ministers
évidemment,
of
on
health,
est
including
d'accord
myself,
en
agree.
privé sur ce qu'il faut
In
faire
private,
pour
we agree on what needs to be done
améliorer
in
et
order
même
to
transformer
improve
notre
and
système
even
de santé,
transform our healthcare
avoir un meilleur
system,
accès aux
to
médecins de
have better
famille,
access to family doctors,
retenir, recruter
to recruit
et
and
former davantage de
retain
travailleurs
and to
en
train
santé,
more healthcare
et
workers,
reconnaître aussi les
and to
compétences des
recognize
travailleurs qui ont été formés à l'étranger pour qu'ils
the
puissent
skills of
travailler
foreign-trained
ici
healthcare
au
workers so
pays,
that they can work here in
réduire les
Canada,
retards en
to
chirurgie
reduce
et
the
en
surgical
diagnostic qui font
backlog.
beaucoup de mal présentement
Right
chez les
now,
gens, chez les
there is a
patients,
lot
chez les
of
familles,
harm being
au
done
pays, et
in the
avoir
country.
un système de données moderne
And
au
we need
Canada.
also
On n'a pas un
a
système de
modern
données
data
moderne au
system. We
Canada, on a
don't
un
have a
système de données
modern
qui est
data
médiocre,
system. We have a
qui
mediocre data
mène
collection system,
malheureusement
and
à des pertes de
unfortunately,
vie
this
et à une
leads to
qualité de
loss of
soins
life
qui n'est pas
and
suffisante.
quality
Quand
of
les
care that is not
médecins
always sufficient.
généralistes, spécialistes, les pharmaciens, les infirmières, les
When
techniciens de
healthcare
laboratoire
workers
sont incapables
are
d'échanger des
unable to
informations entre
exchange
eux,
information
quand en
among
2022,
themselves,
on utilise
in
encore des fax et des bouts de
2022,
papier
faxes and
pour
pieces of paper are still
transmettre des
being used in
informations
order to
sur
transfer
la santé des
information
gens, on
on
n'est pas
people's
à la
health.
hauteur
We are
des
not
besoins du Canada.
meeting the
Heureusement, on
needs
peut faire
of modern-day
mieux et
Canada.
beaucoup mieux
We can do
rapidement, et
better
c'est ce qu'on a
and much
convenu
better
de faire
quickly,
en
and this is
privé
what we
à
agreed in
Vancouver, mais
private
il
in
faut que les premiers
Vancouver.
ministres nous laissent faire
However,
notre
the
travail comme
premiers
ministres de la
have
Santé.
to
Donc,
let
nous obliger
the
à ne pas parler de
ministers of
résultats,
health do
mais
their
à
job.
focaliser entièrement sur les
To
dollars, ce
focus
n'est malheureusement pas un
only
plan en
on
santé.
dollars is not
Mais le
the
fait que vous ne vous
correct way
entendiez
forward.
pas et que
It's
ce
that
soit
the
un
fact that you didn't
sempiternel
agree,
débat,
and
là,
this seems to be
les gouvernements
a
avant vous
circular
aussi, mais
and
en ce
unending
moment, c'est vous qui en
debate.
êtes responsable.
Right
Au
now,
final,
you're
les Canadiens
responsible,
sont
but
pris en otage, là, peu
Canadians
importe
are
c'est la faute
taken
de qui. Là.
hostage. It doesn't matter whose fault it is.
Pour les dollars, à nouveau, il y en a
As for
beaucoup,
the dollars,
et
there
il y en aura
are
encore plus dans les prochains
there's
mois
a
avec
lot of money,
l'augmentation
and
des
there
transferts
will be
canadiens
even
en
more
santé.
with
Maintenant,
the
pour les
increase to the
résultats,
Canada Health Transfer.
comme je dis, la
As
bonne
for
nouvelle, c'est
results,
qu'en
the good
privé,
news is
tous
that
les
in
ministres de la Santé
private,
s'entendent
all
sur ce qu'on doit
ministers
faire
of health
ensemble.
agree
Mais
on what
en
needs to be
public, on n'a
done.
pas encore
But in public,
l'autorisation
we
des
don't
premiers
yet have
ministres ou des
the
provinces pour en
authorization of the
parler et
premiers
pour
to
focaliser
speak
sur
about
ces
it
résultats.
and to focus on results.
Kevin Gallagher, CTV News.
So if it's in the Premier's court, and the Premiers are saying the Prime Minister will meet with them, and the healthcare system's in a crisis, and as you acknowledge, the hospitals are in a crisis, what's the short-term solution to give any of these hospitals that are turning away patients or, transferring patients elsewhere some relief? Can the federal government do anything right now in the short term?
Well, the federal government, as I said a moment ago, has been sending, is sending, and will be sending very significant additional resources to support the difficult work of my colleagues' health ministers. Their job is not easy with the viral situation of which Dr. Tam spoke a moment ago. It's very difficult in hospitals and in healthcare contexts across Canada. So my job is to be an ally of health ministers, to make sure that that significant and additional funding that our government has been committing to is being received by health ministers. And that's the case with the $2 billion just recent investment in supporting health, our healthcare system, and more particularly hospitals in the context of backlogs of surgeries and treatments. The equally important work that we need to do together is to look at the longer term. Our healthcare system has been under severe demographic pressure over the last few years, and over the next few years it will be under increasingly heavy demographic pressures. And to do that, to address that pressure, we need to have a more modern healthcare system, a healthcare system that invests, for instance, in sufficient access to family health teams. Lots of our patients now end up in a hospital because they don't have a family health team to go to. Or they end up in a hospital because not having had an access to a family health team, they end up with more severe health conditions, and then it becomes a lot more complex and a lot more difficult and much more costly, and unfortunately a lot less good in terms of health care and health conditions to end up in the emergency department as opposed to having been able to visit a family health provider prior to this. In addition to that, as I said a moment ago, it's about data and modernizing our healthcare system, making sure that safe and appropriate information on patients is accessible by healthcare providers, and investing in home care and mental health care and long-term care as we have promised to do and as we're doing now.
Okay. So, but you're saying the health ministers that you meet with agree with those reforms and changes that need to happen to the system. However, we're hearing from the provinces that they want to meet with the Prime Minister. They want to move forward on getting the healthcare transfers increased. So what's holding this process up? You're blaming the premiers. The premiers are blaming the Prime Minister. Where's the truth?
Well, premiers have important responsibility. Health ministers have an equally important responsibility, and we need to be given the room to take on that responsibility. We were able to do that. We were prepared to do that, and we were hoping to do that in Vancouver just a few weeks ago. Unfortunately, the premiers asked us not to do that work.
Sir, what can't you share, though? I'm confused. What is it that you can't share, that the premiers aren't allowing you to share? I want to make sure I'm hearing you correctly. The premiers are forbidding the health ministers that you spoke with and have an agreement of some type to move forward with, not to share. Am I overstepping that? Am I misunderstanding something?
Yeah, as you said, and as you heard earlier, there were two key plans, one on supporting health workers and one on modernizing our health system, including having a modern health data system in Canada. We were prepared to approve those plans and to make them public, but we were asked by premiers not to do so.
Emily Bergeron, La Presse canadienne.
Bonjour, Monsieur Duclos.
Hello, Mr. Duclos.
Vous avez souligné que vous et les provinces ne s'entendaient pas sur le 35%, sur le fait que vous dites qu'il est déjà atteint. Donc, est-ce que ça, la reconnaissance là, de votre calcul, que le 35% est déjà atteint, est-ce que c'est une condition sine qua non pour aller, pour cheminer dans des négociations? Puis, si oui, là, vous seriez prêt à aller jusqu'à combien de pourcents? 40, 45% selon votre calcul. Et ici, ça, c'est pas une condition sine qua non. Est-ce que c'est le partage de données? Parce que là, on a entendu M. Legault dire pas de problème, on va vous partager des données. Ici, vous n'êtes pas capable de nous dire c'est quoi la condition sine qua non, alors que les provinces doivent comprendre, il n'y a peut-être pas un risque qu'elles pensent que vous cherchez sempiternellement des excuses.
Là-dessus, il y a trois
trying to find excuses. Well, there's three good news stories here. Number one, we are at 35%.
La deuxième, c'est qu'il y a
Two,
des montants additionnels
there are
et
additional
substantiels
amounts of funding that will be added to this 35%, $2 billion that I mentioned, also another $72 billion for COVID-19, and 3 times $3 billion. One is for mental health, the other for long-term care, and the other for home care. And three, the Prime Minister has already said that we would do more. So these are three good news stories with regards to funding of the healthcare systems for provinces and territories. The other good news story
générer le plus rapidement possible, c'est la bonne nouvelle sur les résultats.
Is the one on results. What we want to do collectively in Canada to have better results with additional investments made by the Canadian government, and this is where we are now when we're discussing with the ministers of health.
Et on a entendu, là, je pense il y a environ 2 semaines, votre collègue Dominique Leblanc dire en mêlée de presse ici à Ottawa, dire que il n'y a aucune province qui a un droit de veto sur la décision des autres provinces de conclure, par exemple, un accord bilatéral ou un accord seulement de certaines provinces avec le fédéral. C'est une question sérieuse parce qu'on pourrait en venir là à vous écouter parler quand on entend quand on entend
we
ce
could reach
genre
this
de
conclusion
discours-là.
when we hear you speak.
Alors là, dans le contexte où M. Trudeau
In the
va
context where
rencontrer
Mr. Trudeau
M. Legault
is going to meet
vendredi,
with Mr. Legault on Friday,
si M. Legault a des
if Mr.
inquiétudes
Legault
que
has
le Québec
concerns
soit isolé
that
dans des
Quebec
négociations,
might be
qu'est-ce
isolated
que
in
M. Trudeau
negotiations,
peut dire à M.
what could
Legault
Mr. Trudeau
pour le rassurer à ce
tell
sujet-là?
Mr. Legault to
M.
reassure
Trudeau
him?
va certainement dire à M. Legault,
Mr. Trudeau will certainly tell Mr. Legault, as he tells me all the time, that the government of Canada will always respect the jurisdiction of provinces and territories with regards to managing healthcare services.
Que le gouvernement canadien prétende qu'il est mieux capable
government
de
of
gérer
Canada
le
will
système de
not
santé d'une province ou d'un territoire. Je suis sûr que c'est la première chose qu'il va
say that they are better placed
et
to
c'est
manage healthcare in the provinces. And this is important, and it is also my first responsibility is to work in respect of the different jurisdictions. And this is a difficult jurisdiction to have.
Mr. Trudeau
will probably also say that we have a shared responsibility. Our roles are different but shared, because we are serving the same citizens with the same funding coming from the same pockets. And also, in Canada, we have the Canada Healthcare Act that requires of the federal government to assume a share of responsibility. Then we have the focus on results. We know that this is what people want. I'm sorry to interrupt, but the fear
qu'il y ait des ententes à la pièce. Est-ce que c'est une crainte qui est fondée?
There will be piecemeal agreements. Is this
au Canada, et on l'a fait en 2017, on l'a fait encore durant la COVID-19.
We did this in 2017 and during COVID-19. Sometimes we need to recognize the diversity of conditions and ambitions that we naturally have in a federation. This is my role as well. It is to make sure that our agreements with the provinces and territories take into account the different circumstances. And I am sure that that's what we'll do over the following months.
Ryan Tumulty, The National Post.
Yeah, this question might be better directed to the doctors, so the minister can take a time out. The report here, the executive summary, identifies that 1.4 million people have long COVID, that you don't know what causes long COVID in terms of the medical interaction there, and really don't have any idea how to treat it. I'm wondering in that context, where does the research begin to try to solve those problems? And is the money that the government has allocated so far anywhere near sufficient?
Maybe I'll start, and then perhaps my colleague Dr. Strong will want to add. We know that the post-COVID syndrome is due to infection by SARS-CoV-2, is due to the acute phase of the COVID. So this thing we know. What we don't know is what causes heart problems, for example, or cognitive problems to persist or to reappear weeks and months after the acute phase has resolved. Okay, so in terms of treatment. Again, we mentioned that it's a complex disease, so you can think of the treatment in a way in three different buckets. One is treating symptoms that we know something about. For example, heart palpitation. For example, hypertension. For example, if there is a diabetes onset. The second one is treating mental health issues. We have at least treatments for that. The third one, which is the most vexing, is how do you treat ill-defined symptoms? So brain fog, for example, or chronic fatigue, or you get exhausted just from going to your medical appointment. And this is where we need a lot of research to understand what's going on. And we also need perhaps to try and see if any of the existing treatments for other diseases can be repurposed. And this is in the context of, clinical studies. So, Mike?
So again, thank you very much for the question. I might tackle it in three different components there for you. So your first one was with regards to how do we treat it? What was your second one? But I'll come at it first for that. Look, the very first thing that one needs to really be looking at in this is that the best treatment for this is the prevention of getting it. And that is crystal clear. We are starting to see very nicely from international data And as Dr. Tam alluded to, getting the vaccine and having at least two doses of the vaccine actually does reduce the risk of going on to get the disease in the longer term. So the very first thing is that be vaccinated. We have highly efficacious vaccines. They do work. The second is that with regards to the actual causes behind it, we are beginning to understand this an awful lot more. But it is the first time that we've seen this illness. This is an incredibly unique scenario for us to have had an acute illness, as Dr. Nemer was referring to, that then becomes chronic consequences. So there are at least three reasons why we see the illness going into the post-COVID condition. The first one is that there is undoubtedly damage that is done at the time of the viral infection itself. So whether it be the heart, whether it be the lungs, whether it be the peripheral nervous system, doesn't matter. And that damage is lifelong in many scenarios, particularly for the lungs, right? So that's a concern for us. There is an immune response that is immediately mounted by this. This virus works to try and suppress the ability of the body to mount the immune response that would be required to kill it. And in doing so, it sets off an immune response that is not only immediate, but long-term. Add that to the damage that's already in place, so you have ongoing. The third piece of this is that the virus itself appears to be able to have longer-term consequences, particularly in some of the degenerative disorders, the neurological disorders with that. So if you take all three of those, I circle back to my first comment. We have never been in a scenario where we've been able to look and see the coming of a disease such as this and know that the way to prevent it is to be vaccinated. And so even if the vaccine primarily helps to reduce the load on the healthcare system, which is critical for it, our argument, and the thing that I would urge, and I urge my colleagues to do, is get vaccinated, not just because of that, but because it reduces the risk of these long-term. So we know a fair bit there, and we're beginning to understand the research. My very final comment on that is we are, as Canadian researchers, we have been incredibly fortunate in that the funding that we've received to look at this has been over and above all the other research that we do around health issues and allows us to work extremely closely with international groups that are doing exactly the same type of thing. So there's not redundancy. We're trying to understand this in real time. So it's a long answer, but it's a terrific question. So I hope I gave you what you're looking for.
And Minister, on healthcare and on these meetings with premiers and health ministers, you know, everyone in this room, I think, is having trouble understanding what happens next, because we have health institutions that are calling in the Red Cross to help out a children's hospital in one of the richest countries in the world. And we seem to have no movement from either side. I understand your desire for more long-term fixes to the healthcare system, but in the short term, the hospitals are overwhelmed. So what are you telling Canadians is going to happen? You're just going to wait until someone blinks?
Well, dollars are there. No, as I said, the CHT increased by 5% last March. We added another $2 billion just a few weeks ago. It will increase again by 10% in this March. We're sending other dollars for other things too, and it's never been as extensive in terms of financial support. And if it were only dollars, provinces and territories could also use their dollars. On average, they have a surplus now in Canada. So it's not about dollars. The dollars are there, either from the federal government or within the coffers of provinces and territories. But even if that's not the case, the Prime Minister said that there will be even more dollars in the future and possibly quite in the short term, but for adjusting our system, transforming our system, making it more adapted to the reality of 2022 and beyond. When Canadians can't have access to a family health team, that brings Canadians to emergency departments. When healthcare workers are tired, exhausted, they leave, and once they leave, the patients cannot be cared for appropriately. When patients and providers can't share data, health data, then it leads to issues of safety and adequacy of healthcare.
David Thurton, CBC News.
Hi, good afternoon, everyone. My question is for Minister Duclos. Canada will receive another shipment of Paxlovid in the coming days. But based on the data that we've been looking at, the treatment has not been widely used. So what will your government do to boost the uptake and the use of Paxlovid?
Well, that's a great question, and there are two angles to that. The second angle, I'll turn to Dr. Tam to answer it, because there has been recent, I understand, recent evidence, biomedical evidence of the effectiveness of Paxlovid, which you might be interested to know more about. But on the first part, which is the accessibility, we have indeed sent hundreds of thousands of Paxlovid units over the last months. It started early in the winter, and we'll be there to share whatever provinces and territories require to care for patients. As you might hear from Dr. Tam in a moment, it has an impact not only of reducing the severity of acute COVID-19, but it can also have other benefits. But I'll turn to Dr. Tam for that part.
Thank you for that question. I think there's a number of things that we can do to increase Paxlovid use. It's correct that the federal government has sent, I believe, at least 700,000 doses to the provinces and territories. So I've been discussing with our colleagues and also the clinical care professional groups as to why and how, why Paxlovid isn't being mobilized as much as we think it could be utilized. There's several different factors, I believe. One is awareness for patients that this is an option. So I think we can collectively do more in that area, particularly those with high-risk conditions or seniors. Increasing their knowledge of how to access Paxlovid in their local area, but also the benefit of Paxlovid, which has been demonstrated not only in the clinical trials, but in real life now, that they can significantly reduce hospitalizations and deaths in high-risk groups, particularly in seniors. That group should talk to their physicians ahead of time. Get prepared, because if you get diagnosed with COVID, it may be a bit late to try and figure out where you can get Paxlovid, and you need to take it within a short number of days. So know how to get your rapid test and know ahead of time where you can get your Paxlovid is important. Healthcare providers, I think, have been a bit concerned about using Paxlovid because of the drug-drug interactions. We know that that can occur. But collectively, people can figure out which patients can still use Paxlovid. And I think increased awareness and education amongst health professionals is something that we can assist with. And then there is access, because you have to access a test and then the drug really fast. And you've seen in Ontario just recently that they've announced pharmacists can now prescribe Paxlovid after someone's got a positive rapid test. At the beginning, we didn't have a lot of supply, so people insist that you have to have a positive COVID test, and then in certain groups. And they've widened the eligibility in provinces now so that more people can get it and get it faster. I don't think that's the same method everywhere, but I think sharing best practices on how we mobilize it more, I think will be very helpful, particularly in seniors.
Just to follow up, we've budgeted some $2 billion for COVID treatments, including Paxlovid. Minister, are you concerned that there will be waste?
Dr. Tam, do we have evidence that has been wastage in the use of Paxlovid now?
I don't have specific numbers. All I can say is we have to follow the science on the evolution of the variants as well. Some of the most recent variants, BQ1.1, et cetera, are immune evasive. Those monoclonals don't work. So that will be regular need to not use them, because that would not be helpful to patients. So I think that's totally understood. So we now have antiviral agents like Paxlovid and also remdesivir that has to be given not by orally, so it's much more difficult to give potentially, but there are these options where the viruses have not eluded the drug effectiveness, and these can continue to be used. But we have to monitor susceptibility of the virus to these medications. And I do think that we mustn't let our scientific knowledge and biomanufacturing of these drugs go to waste, because we need to now adapt them to future use as well. But while I don't have the numbers, I think there's necessarily a need to park those drugs for now if they don't work.
I just want to add that this is a perfect example why data sharing is extremely important. The reason that pharmacists and physicians may be reluctant to prescribe Paxlovid, which for now is really the best game in town in terms of, an antiviral, other than, of course, the best, which is prevention, is because they don't have perhaps the full file of the individual. They don't know, what other diseases they may have had in the past, what other interventions they may have had, what drugs they're taking. And as Dr. Tam said, there are, known drug-drug interactions. So you don't want to, be providing something to an individual that may harm their health. So I thought that perhaps it's like a good example of why, the sharing and the availability of health data is absolutely important for caring for individuals. Thank you.
Do you have another question, David? Raphaël Pirot from QMI.
Oui, bonjour. Écoutez, cette question est pour vous, M. Duclos.
This question
Donc,
is for you, Mr. Duclos.
On est déjà rendu à 35%
at 35%
de financement aux provinces. Moi, ce que je me demandais, en fait, c'est tout simplement, est-ce que les PM des provinces, des territoires, est-ce que c'est une grande mascarade pour soutirer plus d'argent du fédéral? Est-ce que vous les accusez de jouer avec les chiffres? Qu'est-ce qui se passe?
Je dirais deux choses. La première, c'est qu'il faut, reconnaître ce qui est déjà
we have to recognize what has already been done, and two, we have to recognize that the Prime Minister of Canada said that more would be done. When we talk about recognizing what has been done, if we calculate correctly, we are at 35%, and we have been for 45 years. Sometimes a little bit over, sometimes a little bit under. During COVID, it went almost up to 40%. Now, we're around 35%. In addition to that, there are additional amounts that are added.
Mais on doit aussi dire en même temps que ce n'est pas l'objectif, c'est pas de faire une comptabilité. Les Canadiens et les Québécois ne s'intéressent pas à cette comptabilité.
Is to render this accounting. This is not what Canadians really care about. If we look at only the numbers, this is not what Canadians are concerned about. They're concerned with results. And so we are looking at focusing on the results that we would like to reach and how the federal government can invest in order to reach the desired results for Canadians. If the Canadian government will increase funding, this is the true discussion. It's the discussion that needs to be held. What are the results?
Moi aussi, ce que j'aimerais savoir, c'est
qu'il y a plusieurs
premiers ministres qui ont déjà dit qu'ils allaient, par exemple, comme M. Dubé, mettre sur pied un tableau de bord avec des indicateurs. Peut-être que ça ne satisfait pas, c'est pas exactement ce que vous recherchez. Vous aimeriez peut-être quelque chose de plus central. Mais est-ce qu'une condition, en fait, pour finalement mettre un terme à ce débat-là, ça pourrait être tout simplement, vous devez investir l'argent en santé, et c'est tout.
Laissez-moi vous dire quelque chose.
Well, I have something to say. Mr. Dubé's
de données en santé, il est
plan for healthcare data is
excellent. Ce genre de plan qu'on a
This is exactly the kind of plan that we want to support, not only in Quebec, but elsewhere in Canada. Other provinces have plans as well that are very good with regards to healthcare data. Data saves lives. When people arrive at the emergency room and the doctor on call is unable to know if this person has been vaccinated, what drugs they're taking, what are the recent tests that have been conducted, this sometimes jeopardizes the care that they might receive. So it's not receiving a paper copy in CC. No, we're talking about concrete data, healthcare data on people's medical files. Provinces such as Quebec want to make this more easily accessible to the healthcare providers.
Si on serait rempli.
Vous voyez à quel point on pourrait s'entendre
rapidement si les premiers ministres nous donnaient la permission aux ministres de la Santé de convenir de ce genre de résultats ensemble.
Donc on y est proche.
So you're close? You're close to an agreement?
On était prêt à y arriver à Vancouver.
Well, we were close in Vancouver.
Vancouver, quelques jours avant,
but a few days before, my colleagues, the Minister of Health, received a call from their bosses and were told to not reach a final agreement and to not talk about this in public.
We're now going to turn to Zoom. We'll have time for one or maybe two questions from Zoom, and we'll start with Mike Crawley from CBC.
Thanks for taking my question. My question is for Minister Duclos. You mentioned data saves lives, and one of the biggest concerns in the flu season, as Dr. Tam mentioned, is the impact on children. And there's a piece of data that we've been wanting to find out, which is the deaths of children from flu. British Columbia was transparent about this. They announced when there were flu-related deaths from children, but other provinces are not giving out information about children's deaths from the flu. So, Minister Duclos, what do you believe should be the policy here? Should there be transparency, or is it right to keep this information secret?
Well, let me first say that these deaths are tragic deaths. No, these are numbers, but more importantly, and much more importantly, these are real children, families, grandparents and parents who are grieving the loss of those children. Having said that, yes, data saves lives. No, obviously we don't know whether it would have been possible to save those children's lives with better access to data. But as Dr. Nemer said a moment ago, and as Dr. Strong knows really well, and as Dr. Tam knows really well with her work with other public health officers across Canada, data does lead to better treatments overall, but also better treatments adapted to the conditions of the patients that workers are there to look after. And in Canada, unfortunately, we don't have a world-class health data system. We have a mediocre class data system, and we can do a lot better. The great news is that all health ministers agree that we should and must do better. And the equally great news is that we will be there, as the Prime Minister said, to support those efforts through increased support to provinces and territories.
Well, my follow-up is for Dr. Tam. From the perspective of public health, is it best to publicize statistics around deaths from something like the flu in children for the purposes of, as British Columbia did, in then encouraging parents to get their children vaccinated?
Well, I think information is extremely important for informing the population about measures to take to protect themselves. So that is a fundamental aspect of public health, I think. One thing is clear that, of course, something like influenza we know happens every year, doesn't get as much attention or hasn't been paid as much attention as COVID has. We've gained some capacity from the COVID experience to show that we are capable of monitoring specific health information in real time. In the time of an urgent situation. So I think we can build on that experience. One thing that I do have to clarify is that children do get serious outcomes from influenza, although majority of them, if they rest up properly, can recover at home, but particularly the youngest kids. And we are also in a special situation that we're just coming into increasing contact post 3 years of reduction in contact during the pandemic. I think because the numbers are small, which we're grateful for, the numbers of deaths, provinces are often very careful about privacy. So even British Columbia, until you get above the number 5, it's difficult. We don't get that level of reporting nationally too, for the fear that individuals can get and identify very easily. That is something that we have to work through because that is important to individuals. But instead of data custodians, we need to be data stewards and manage appropriate data, but also informing the public so that they have the information that they need. Just while I have the mic, I did find the Paxlovid numbers, so we did allocate over 700,000 treatment courses of Paxlovid to provinces and territories, while we've procured 1.5 million courses. We have a lot of rapid tests that have been sent out. So together, in combination, these two measures can help reduce the impact of COVID-19, particularly in the high-risk groups.
Okay, and we'll take one final question on Zoom. Alice Gerard-Boisé from La Presse.
Bonjour, les CDC des États-Unis ont annoncé aujourd'hui que la COVID longue a causé au moins 3500 décès. Au Canada, on estime à combien le nombre de décès qui ont été associés à la COVID longue?
How many deaths in Canada can be attributed to PCC?
Dr. Strong or Dr. Nemer?
I think the simple answer is we don't know yet. And, you know, that's another area where data is unfortunately missing from across the country. It's very difficult really to, even the CDC in the US said that they believe these may be underestimates because there is no clear definition and medical sort of description. But here in Canada, I think that we're still figuring this out.
Certaines personnes ont désormais la COVID longue depuis plus de 2 ans, puis ils ne voient pas d'amélioration dans leur état. Il n'y a pas de traitement généralisé disponible au Canada non plus pour les aider. Donc, à court terme, comment vous comptez accompagner ces personnes qui commencent à perdre espoir?
Ben justement, la raison pour laquelle nous avons fait part publiquement de nos recommandations et particulièrement l'importance de reconnaître que le symptôme existe, d'accélérer les informations à la fois au public mais aussi aux soignants eux-mêmes. C'est pour pouvoir aider à soigner ces individus-là. Je voudrais juste peut-être préciser que ce n'est pas juste au Canada qu'il n'y a pas de soins. Il n'y en a pas ailleurs non plus. Donc, ce n'est pas une condition pour laquelle on sait comment faire. On est en train d'apprendre encore. Et d'où l'importance que la recherche et la prestation des soins soient vraiment intégrées pour qu'on apprenne à fur et à mesure de nos propres expériences. En ce moment, il y a certaines provinces qui ont déjà commencé à mettre sur pied des cliniques multidisciplinaires où on a plusieurs spécialités de médecine. On a aussi la réadaptation, des soins psychologiques également, etc. C'est vraiment un très bon début, mais il n'y en a pas suffisamment et l'accès pose toujours problème. Donc, moi, je vous dirais c'est d'où l'importance vraiment d'accélérer la recherche afin qu'on puisse plus rapidement offrir des soins et améliorer la qualité de vie de ces personnes-là. Je ne sais pas si Dr. Strong aimerait ajouter quelque chose.
Dr. Strong, do you have something to add?
Really, I would simply echo what Dr. Nemer has been saying as well, too. But, you know, for those individuals who, you know, have symptoms that are persistent for that period of time, and they're, you know, one of the issues behind all of this is that many of those symptoms can, in fact, look like other. You can be misdiagnosed in the sense of they are fairly subtle or they're cumulative look. So one of the first things that we recommend right off the top is ensuring that you are seen by a multidisciplinary team or by specialists in the area to make sure that this is not just simply ascribed to being PCC. So number one on that is kind of get it right and make sure that you're being looked after there. The second is that we don't have specific therapies that will bring a full stop to this right now, but there's a lot of symptomatic therapies that can be done, and Dr. Nemer started to allude to those. The final piece is that, like everything that you know we've looked at and had to face over the course of the last several decades of new diseases coming, it takes time and it takes research to get those answers. But this is the right direction. This is what needs to be done. So I'm encouraged that we're moving, and the report of Dr. Nemer is helping to guide us on that.
Thank you so much. This will conclude today's press conference.